Oh, we went red.
That's a good thing.
Oh,
That
okay.
means we are live.
Excellent.
So, it's often referred to as Australia's national cancer. And we've recently again earned the title of Melanoma Capital of the World. So keeping this in mind, the chances are that you or someone you might know may be diagnosed with melanoma. Hi everyone, and thanks so much for joining us today for our episode of Epworth Live focused on melanoma. So today we're going to be discussing everything from symptoms to treatment to prevention, and I'm so grateful today to be joined by these three lovely gentlemen beside me. So I've got Dr. Dean White, Dr. Phillip Parente, and Dr. Frank Lynn, who are from Eastern Melanoma Clinic. If you have any comments, questions, stories, anything you'd like to share, please feel free to pop them in a comment below and we'll get back to you as soon as possible. So I guess today we'll just kick off by getting you to tell us a bit about yourselves and what you do and a bit about Eastern Melanoma Clinic.
Okay, sure. Dean White's my name. I'm a specialist plastic and reconstructive surgeon. My private practice is based at Epworth, Eastern in Box Hill. I'm the director of the Clinical Institute for Head and Neck here, and my other work's at Eastern Health, which is the public hospitals of Box Hill and Maroondah essentially, and I'm the director of plastic surgery in that building.
Thank you.
I'm a medical oncologist, and where I work at Epworth Eastern, but also I'm the director of the Hematology Oncology Unit at the public hospital Eastern Health, which includes Box Hill, Maroondah, and narrow ranges where we have oncology units there.
Hello everyone, so my name is Frank Lynn. Like Dean, I'm a plastic and reconstructive surgeon. I have a public and a private appointment, and my private practice is here at Epworth Eastern, and I have a public appointment at Box Hill Hospital, where I'm the supervisor of advanced surgical training there.
And would one of you like to give us a bit of an overview of Eastern Melanoma Clinic, how that came to be?
Sure. So what was happening in practice was we were working together collegially. We had all the specialists together. We were attending multidisciplinary meetings where we don't just get one particular craft group. We have the specialist plastic surgeons, the medical oncologists, the radiation oncologists, radiologists, and the histopathologists, all discussing particularly complex melanoma cases. And this is networked across various other units within the state. And that's what we were doing in practice, but really it was just a matter of advising everyone that that's what we were doing. We were managing both private and public patients through that mechanism, and we just thought it was a good opportunity to point that out to people, that was what was actually happening, and the care you were getting, just instead of rather going to just one specialist and then having to be referred independently to others, it was to coordinate the care, which is certainly the way we think it should be done.
Okay, great. And I guess we'll just start from the beginning here. What is melanoma?
So a melanoma is a type of skin cancer, and as Louisa pointed out, it is quite a common skin cancer in Australia. The cancer is derived from a type of cell in the skin called a melanocyte, which normally makes pigment. And that's the reason why we normally associate melanoma with a darker or a pigmented type of skin cancer. Compared to other types of skin cancers that we see in Australia, it tends to be more on the aggressive side, and it has a higher risk of sort of spreading to other organs. And for this reason, we tend to take it more seriously. We tend to treat it more aggressively, and it tends to garner more media attention.
And are there some people who are more at risk of being diagnosed?
Well, yes, they are. So the typical at-person risk is the person of Anglo-Saxon descent, who particularly has blonde or reddish hair with blue eyes and fair, freckled skin. And another risk factor, people have multiple moles on their skin is another risk factor. But we need to make it really clear that, in my opinion, that anyone in Australia is at risk. But yes, certain populations are more at risk than others, but just living in Australia is a risk factor within itself.
Yeah. And you sort of touched on it there with the moles, but what sort of symptoms should we be looking out for?
Well, I like to make things very simplistic when I speak to patients. So it's really, I call it the A, B, C, D, E. You know, A for being asymmetry, meaning that, you know, does not look regular. B for irregular borders. C for a different colour. D for diameter for a large lesion. But E is the most important, which is evolution, which meaning that if something changes, you need to notify the doctor.
Okay, and on that note, how often should we visit our doctor to get our skin checked?
So there are subgroups of people. So if we're just talking about the general community,
yep.
Most people really should be just coordinating that with their general local doctor or their family doctor. I would say every 6 or 12 months is general health care if you're just getting a skin check for the vast majority of people. That would be a good thing. It's probably much more than most people are doing. And then depending on other factors, whether you've had other types of skin cancers or melanoma, we then start sub-stratifying people, and particularly if you have a strong family history, where that might be increased with regularity, either with the local doctor, or it might be increased if you may be getting surveillance with, like some local doctors have subspecialty interest in skin cancers, or even referral to a dermatologist, just for increased surveillance. But for the vast majority of people, if they're just getting regular skin checks with their local doctor, that's what we're suggesting. Okay,
great. So I've noticed online there's been a whole lot of melanoma predictors pop up. I just wanted to see what you think of these. Are they accurate?
I'm after the fact, so
yeah.
No, look, I think I'm aware of those online predictors, and essentially it's just another way of categorizing our risk for melanoma. And as Phil said, if you live in Australia, everyone's to some degree at risk. So, and it's fine to go online and get more knowledge about your level of risk, but really there is no substitute for sort of seeing your medical professional at a regular basis and actually having your skin checked. And just to reinforce what Dean said as well, I think GPs are often at the front lines of skin checks in Australia, and they're really at the cold face of it all. And there are GPs who will have more of an interest or a specialised interest in doing skin checks, and so it's important to actually have that conversation with your GP and say, do you have a skin interest in skin, or should I be seeing another person who may do?
Okay, yeah, no, I think that's really good advice. I did a couple of the online predictors, 2 different ones, and got very different results. Yeah. So I thought, not sure if I should just go speak to a doctor instead. So on to treatment. How has treatment changed in the past few years?
Well, I might just speak about the early things and then speak about the real evolution. So if we went back 100 years, our understanding of melanoma was fairly poor. And largely it was just treated with surgery. The margins that were taken were very wide, 5 centimetres all the way around, which was quite extensive. Probably, didn't really make any significant difference to the outcome, and was quite a burden from an adherence point of view, if nothing else. As the information we gain and get a better understanding of melanoma has evolved, those margins have essentially shrunk. We now have a much better understanding of what a required margin is to treat earlier skin cancers. So just to take a broader view, we divide melanoma in essentially how thick the melanoma is. And the earlier ones, which haven't spread, need a significant margin, either 5 millimetres or 10 millimetres all the way around. But that sort of hasn't really changed in probably the last 20 years or so. What has changed significantly is our treatments and interventions and workups on investigations in the more advanced type of melanomas. And it would probably be fair to say, although I'm happy to be corrected by those to my left, is that maybe up to 10 or 15 years ago, the treatments for more advanced melanoma were fairly limited and didn't really have great long-term prognosis, but I think probably in the last 5, 10, 15 years, that from my point of view, the more medical treatments have really evolved quite a lot for the treatment of melanoma, which is where I segue to the man that actually knows about these sort of treatments.
So Dean's correct. So 10, 15 years ago, our only treatment for melanoma was chemotherapy, and really there was no change in survival.
For the more advanced melanoma.
These are some people, if people got stage 4 disease. So you have your initial melanoma in the skin, they get surgically treated by surgeons like Frank and Dean. Then it may come back in the lymph nodes, it still gets surgically managed by an operation, still potentially curative. But then if it was to relapse later on, that's stage 4 disease. And the possible sites, the common sites in melanoma are the brain, the liver, the lung and the bones. 10, 15 years ago, the outlook was exceptionally poor, where survival was only measured in months and chemotherapy only improved that by weeks. So the question was it actually worthwhile treating? And really, over the last decade, there's been a multitude of new advancements, which has led to melanoma being the worst cancer to get. So we used to say that melanoma gives cancer a bad name, but now it's actually one of the better tumours to treat as compared to lung cancer, even breast cancer, or kidney cancer. The results are quite spectacular. And there's 2 types of therapies that we do with a targeted therapy. Half the people with metastatic disease will have a gene mutation. It's not a gene that you inherit or a gene that you pass on to your children. It's what the sunlight activates in the skin to cause the cancer. And it's not it's not an academic mutation, which makes me sound intelligent. I try to sound intelligent, but it's a 1 in 2 chance. And if you've got this what's called BRAF mutation, we have now medications which target this mutation with a 95% response rate. That's versus 5% in the old days. So we've gone from 5% to 95%. And the duration of response is quite prolonged. It can be measured in years. And some people achieve a complete response. And if you're BRAF negative, then we do what's called immunotherapy. So we have drugs which harness the immune system to kill the cancer with response rates not as high as 95% in your order, depending if we do single or a double action immunotherapy, but response rates in the order of either 50-60% up to 80%. But the immunotherapy, the responses are far more durable. And I have patients who've had immunotherapy who are alive, diagnosed with metastatic disease 5, 6 years, 7 years, 10 years down the track in the patients who participated in the initial trials a decade ago. We know that people achieve a complete remission. I won't say the word, but people are in complete remission 5 years post-treatment and living free of disease.
Wow, so the outlook for patients has improved a lot.
Correct.
So if I could maybe comment, one of the issues, particularly if people have that initial diagnosis of melanoma, it's quite a catastrophic diagnosis for people to receive. But the vast majority of people with melanoma, particularly early on with surgery, are largely cured by having a surgical procedure.
Yeah.
It's one of those cancers you can never really ignore or turn your back on. You need constant surveillance and follow-up. But most people, particularly in the early stages, and this is why we encourage people to get onto these things earlier, are completely cured. And it used to be that if you were cured with surgery, it was all great, and if you weren't, you're in pretty big trouble. So even now, still the primary treatment is surgery, and the ones that surgery has not been completely effective for just because of the nature of the underlying disease, we now have quite an armamentarium, and they're still evolving, and this is why we think there's strength in multiple streams of specialists being involved, because for me it's very difficult to stay on top of all the immunotherapies and all the targeted therapies because they keep changing, there's multiple trials, there's different criteria to enter them, and so that's constantly being updated as a team approach about what the best treatment is. But I think the message is, if you get onto these early, the vast majority are managed and cured with surgery, but if you're unfortunate to be in that small group where it's not, there are now quite effective next line treatments.
Okay. And I think you've sort of touched on it there, and we can sort of see it even in action here, but what are the benefits for the patient of a holistic, multidisciplinary approach?
Streamlining care, and I call it having, you know, 5 heads are better than 1. So really having an evidence-based approach, and making sure that all bases are covered, and that different disciplines put in their expertise to give the best outcome for the patient.
And finally, I guess I'll just ask, what can we do to reduce our risk of melanoma?
I think it just follows on from what's already been said, is that the vast majority of melanomas can be treated without having to go to the so-called big guns, and the real emphasis is going to be on early detection. So just, you know, being aware of the risk factors, you know, such as age, sun exposure, and so on. Being aware of that from a very early age is really important. You know, the messages that's been around for the last 15 or 20 years in terms of prevention is still there. So, you know, the slip, slop, slaps, and so on. But there is now more of an emphasis on, you know, regularly getting that checkup, because I suppose, as all the experts have said, an earlier melanoma is much more easily treated, and the word that Phil didn't want to say is cure, but you know, it is much more likely that can be achieved potentially if it's a very small melanoma and a very early melanoma. But, and as Dina said, even if that were to be the case, that nowadays we do have a very streamlined, very efficient service that combines early detection, early treatment, as well as more advanced treatment in the one setting, if you like. So which is what constitutes, which is what gave rise to the idea of a multidisciplinary Eastern Melanoma.
And I suppose that you alluded to the predictors, and a lot of those you can't do anything about. The genetic makeup, your how old you are, but the main thing is limitation of sunburn and exposure to a lot of sunlight. So fortunately now in Victoria, solariums are banned, because that was a way of just generating melanomas, particularly in young people, and particularly minimising exposure and minimising the amount of sunburn, particularly when you're younger, because that's a real risk factor, is the amount of sunburn you've had, particularly as a child. So, you know, all the things in the primary schools now, like no hats, no play, and all those sort of things, they're really important. That's why, because we see the effects of that several years down the track. I found out today there's a no hat, no play policy for corn rolls as well.
Perfect. All right. Well, thank you so much for joining us today. We really appreciate you taking the time to come and share your wisdom. And thank you so much to everyone who's tuned in. Remember to like Epworth on Facebook to keep up to date with all the latest Epworth Live. Thanks, and we'll see you next time.
Thank you.
Thank you. Bye.